The next story is even more interesting. Actually, this is really hot out of the press. This was reported actually 2 weeks ago, not in a medical journal, but in New York Times, front page news. Dr. Lucas Hartman, I had actually the pleasure of listening to him talk at one of the conferences, cancer conferences. Very famous oncologist, and he's a leukemia researcher. He developed, unfortunately, acute lymphoblastic leukemia himself. And a very aggressive type of lymphoblastic leukemia, he was failing all kind of treatments. So, when everything was exhausted, all the standard modalities were exhausted, his team in his lab decided to sequence him, his leukemia, and the RNAs, all the RNAs. So they sequenced, they dedicated the whole lab for him. The university dedicated the supercomputer for doing this research. And within about 24 days, they found that his tumor is driven by a particular kinase. And luckily, there was already a drug called sunitinib, which is in fact approved for kidney cancer, that would block that particular kinase. And he was started on sunitinib and achieved a remission. Now, this is remarkable in multiple levels. For one, it shows the way we subclassify cancer is probably not right. We classify cancer where it is from. If it's from blood, it's leukemia. If it's from the lung, it's lung cancer. Whereas cancer is a disease of the cell and the underlying mutation. Now, if somebody has TB of the lung, they may have hemoptysis. If they have TB of the kidney, they have hematuria. They have TB of the stomach, they may have abdominal pain or diarrhea. But we treat all of them with TB treatment. We don't have separate treatment for TB of the lung versus TB of the kidney. Cancer is very similar to that. We get too focused on the organ of origin. Whereas what is the real story is what is underlying mutation. So this Dr. Hartman's leukemia was very similar to kidney cancer. So this is a very interesting development in leukemia and in oncology per se, that we are going away. Of course, for surgical and radiation treatment, organ of origin is important. Whereas for oncologists, I think we are going more and more into find out what is the abnormal mutation that is driving the cancer. So, and the third, I think the best part of the story is, you could be the smartest doctor, but so be very nice to your colleagues and your co-workers, because they were working 24/7 to find this mutation. Now, the third example, much more common disease, when you think of diabetes, type 1 diabetes, we always think of an acute onset event. This child or a young adult comes with diabetic ketoacidosis. One of the most acute presentations for a chronic disease. But here in this study were patients who had the genetic diabetes. We know that there are about 20 or 30 genes that are involved in type 1 diabetes, and all of them actually are immune regulators. Type 1 diabetes is immune mediated. So these patients were followed prospectively, and what you can find here is that you could find the antibodies. I'm sorry, Unni is here. Unni can describe it more in detail. This is actually a slide from Ambika, my wife. But you could follow these antibodies many years before they actually develop diabetes. Now, we could have never thought type 1 diabetes is preventable. But actually it could be preventable, because we didn't know how to diagnose type 1 diabetes before somebody developed diabetes. Now, we can't test GAD antibodies in every child, but we could select out who are genetically predisposed, select and screen them for the GAD antibodies, and do something before all the beta cells are destroyed. Now, this is where prevention becomes more 21st century. We are talking about preventing diseases that we were unable to prevent in the past. So this is an entire field that is going to explode in the coming years. Now, switching gears here, no talk on technology is complete without talking about mobile. Now, I don't think any technology has penetrated as fast as mobile. I don't think even putting on clothes have penetrated that fast. Now, this is a cartoon here. As you can see, you carry your cell phone all the time. Now, this is just to show the rapidity of mobile connections in the world. Now, it is actually very lakhs in India was the mobile base in India is 929 billion. So that means, maybe a couple of newborns and some very old people, we have cell phone for everyone else. So this is a remarkable technology with extreme penetration. Now, cell phones are not phones anymore. Many of you use so-called smartphones. About 1/3 of global phone sale in the last year were so-called smartphones. Where making a call is one of the thousands of functions you can do. It's not a phone anymore. It's become a very powerful computer. You can do a ton of stuff. You could talk only on mobile phone and technology. It's an entire talk on its own. Couple of programs here. I don't know if there are any hobbies here. But there's a program called, of course, Raj is here. There's a program called ashraf, which actually you can monitor the fetal heart rate with your iPhone. These are not expensive, complicated programs. You can turn your phone into a microscope. And of course, many of you might be using programs like Hippocrates or one of those quick programs to look at drug interactions. I could actually, go to the hospital and, even if I have forgotten the stethoscope, I'm okay. But if I don't have my phone, I feel really handicapped. Because a lot of things like drug interactions, how can anybody remember those things? So you have this thing at your fingertip, and you can really practice much safer medicine with that. How about monitoring? Now, one of the things with technology is things are not only getting powerful, it's getting smaller in size. Now, as you can see here, some of the monitors are becoming like type 2. This is a monitor that can monitor all the vital signs and your sweat secretions and a lot of other things, a couple of new vital signs. This is a mobile EEG. Many times just like if you have problem finding if the patient has a seizure, so you can have an EEG that the patient can wear in real life. This is something you can buy from Amazon for about $120. You put it on your head and it will show you how good is your sleep. It will show you something called a ZQ score, like an IQ score. It will give you a score, how good is your sleep. A lot of people have problem with sleep these days. So these are a couple of technologies that's coming up in monitoring. Now, when you combine the advances in monitoring, how small they're getting, combine that with the fact that everybody is carrying a cell phone, you're reaching a level where you could actually have the patients monitor themselves. And we already have programs that are secure in your iPhone. You could potentially, this is definitely going to come in the next 10-15 years. You could have small monitors that will detect extremely small levels of, say, SCEA or other cancer-related proteins. Or it could detect extremely small levels of troponin before the patient even has chest pain. So the patient is going to see the doctor not when they get a heart attack, not when they get a stroke. So these are things that is going to be in the future, and this is not far-fetched by any stretch, because this is rapidly developing and a lot of research is going into it. Now, some of you might be Star Trek fans here. If you do, you might remember Captain Kirk. He used to diagnose by just pointing his phone around. Now, Qualcomm is the largest provider of computer chips for smartphones, and they have a prize actually named the tricorder prize, and it's actually several multiples of Nobel Prize. And what they are trying to do is a device that could do what the tricorder actually could do. Now, with that kind of money, there will be a lot of people working on this kind of projects. So soon you will be finding things that should be able to do a lot more than what you can do now. Now, it is good to have a lot of data. You would like to know your patient's heart rate, your blood pressure, your vital signs, but sometimes you can get overwhelmed by data. As the picture shows, data useful information is 5 kilobytes, whereas data useless information is 500,000 gigabytes. So how do you manage when you have this much data? You remember the old days, our discharge summary, our patient's chart was 1 page. Now, if you are in any kind of a bigger hospital, you could have the patient's chart multiply very quickly. Imaging, pathology, other consultant reports. So, as humans, we can only find out, we don't want too much information. Otherwise, you will have to have one doctor per patient, and that's not possible. So how do you deal with this problem? So I'll just give you a small case scenario here. 32-year-old with new onset diabetes, she is not obese. So how do you currently manage this scenario? How will you manage this scenario in the world of molecular medicine integrated with an electronic medical record? A lot of you might be using electronic medical records, but the current EMR system is basically turned what we do in paper into electronic. It really is not using the true potential of computers. But actually, to do a true potential of computers, how do you use it? So, when you have something like this, it will show you a diagnostic alert. It says, the patient fits the profile of Modi. So, it will ask you to order Modi genetics. It is really like your professor standing on your shoulder and telling you, this patient looks like Modi. Because it's a computer, you don't have to feel offended, I don't think of it. So, you don't have to, remember, the program, it is programmed in the appropriate way. Now, the next time you are going to give the patient glucose, only is going to correct me if I'm wrong again here. But it will say, okay, you are trying to give the patient glucose. Now, based on the genomic data and the phenotypic expression of the patient, the best treatment for this patient is the sulfonylurea. Now, an endocrinologist will definitely know this, but a practicing doctor, an MBBS doctor may not remember this. But when you have an EMR system, that can actually integrate these kind of things. Your quality of care could improve dramatically. Now, a brief couple of slides on nanotechnology, which in my opinion is going to be the information technology of 21st century. So, nanotechnology is basically technology of devising equipments at the nanoscale. Now, this appears kind of new for us, but life has been doing it for billions of years. Every cell, every bacteria, every protein we make is nanotechnology. Only difference is that now we are able to do nanotechnology deliberately by force, by humans are able to do it. Every computer, every bacteria is a nanofactory. But the difference now is we could create things like a tiny RNA molecule. Eric Drexler here, he is considered the father of nanotechnology. He wrote a book called The Engines of Creation, a very readable book even for lay people. But basically, he's the one who actually is the godfather of nanotechnology. Just to show you a size scale, nanotechnology means extremely